ground for this semester, and we have the Department of Internal Medicine doing it, and the crew is around. And it is indeed, they chose a very important topic. Some of these topics, you may never get someone to teach you before you face them, either on a patient when you're already qualified, or before you see a question or two in exams. It's not one of those topics that you will have someone lecture you as an academic class. It is one of those conditions that's slightly rare, but very important, cutting through all ages of the population. And it is my sincere hope that we will all benefit from this presentation. Hopefully also a lot of your colleagues who are not here will come, and we all benefit. So Mark, please, and the crew, the floor is yours, and we are happy to receive and contribute when we can. Oh, I thought it was now mine.
All right, members, you're welcome to our inaugural grand round this semester, and we are happy to be presenting as internal medicine. We shall be presenting together with pathology and pharmacology. And we want it to be as interactive as possible. You should ask all the questions that you have always had about the cases on the wards, and you should also give some ideas, because we assume you have read, isn't it? Yes, so we shall have Mr. Joseph Odoi present the case of a patient who we saw some time back last year. And then Dr. Yahaya will present about the pathogenesis of the disease. I will present about the epidemiology, clinical presentation, and diagnosis. And then we're supposed to have Dr. Tolu, he's on the way to this place. He will present the treatment. But before the treatment, the pharmacology team will remind us about the drugs that we use to treat this condition. Yes, so let me take this opportunity to welcome Mr. Odoi to present the case.
Our dear lecturers present and the students around, good afternoon.
Good afternoon.
I would like to take this opportunity once again to welcome you all to this once again session of the ground round. I'll be taking you through the case presentation, as Doctor said previously. Without wasting much time, let me start. So I'm presenting AH, a 25-year-old female, Zanite Sot from Soroti. The next of kin was the mother. Her education level was university. She's a single woman. She was admitted on the 16th of September, 2023. And she spent 5 days and was discharged on the 21st of September, 2023. The presenting complaint that she had was skin hypopigmentation for 2 weeks and general body weakness for 1 month. So AH had been unwell for the past 1 year, and she had progressive history of generalized weakness and fatigue that worsened over the past month prior to admission. This was associated with intermittent low-grade fevers, mostly in the evenings, and occasional night sweats. And she also had unintentional weight loss of about 7 kilograms from 55 to 48. She also had intermittent muscle pains, small joint pains, but she didn't have any joint swellings or stiffness. There was no history of polyuria, polydipsia, and polyphagia. And she also didn't have any history of heat or cold intolerance. 2 weeks prior to her admission, she developed hypopigmentation of the skin that started on the face, that is over the cheeks, and it spread over to the forehead, to the anterior part of the chest, and to the upper part of the back. As you shall see in front, there are some pictures. She also reported that she felt uncomfortable when exposed to sunshine, and she preferred to wear long-sleeved clothes. She also occasionally developed an itchy rash after exposure to the sunshine. And she also noticed that her hair was easily removable from her scalp, and that her friends had commented that she was looking older than her real age. So that was the history of presenting complaints. So on the review of other systems, on the cardiovascular system, there was history of easy fatigability, palpitations, dizziness, and bilateral lower limb swelling, but there was no history of orthopnea and paroxysmal nocturnal dyspnea. Respiratory system, she had no history of cough, chest pain, difficulty in breathing, hemoptysis, and wheezing. The central nervous system, there was history of prior convulsions, 1 episode. That was, I think, before admission. She also had on and off headache, but she didn't have history of focal weakness and blood vision. On the genitourinary system, she had a normal urinary output. She also had history of dysuria, but there was no hematuria. She had a normal frequency of urination. She didn't have any genital swellings, discharge, and itching. On the gastrointestinal system, there was history of oral sores, loss of appetite, mild epigastric pain. However, there was no history of dysphagia, vomiting, diarrhea, abdominal distension, and odinophagia. On the past medical history, this admission she had was a self-referral, and she had had previous multiple admissions for the similar complaints, but they were treated as malaria and typhoid, but there was no much improvement. Her HIV status was unknown, and she had never been treated for tuberculosis, and she didn't have any history of, she didn't have any chronic medication at that time. And there was no, she did not have any chronic illness like diabetes mellitus, hypertension. However, she reported she was vaccinated for COVID-19. On the past surgical history, she didn't have any history of a blood transfusion, minor or major surgeries, and there was no history of any major trauma. On the family history, she's the 5th born of 6, all alive and living with her mother. She's single with no children, and there is no history of any similar illness in the first-degree relatives. On the social and occupational history, she lives and works in Kampala, and she owns a boutique. She doesn't smoke, and she also doesn't drink alcohol. On her idea of the illness she had, she reported that she could have been bewitched by her competitors at her place of business. Then her concern was the skin blistering and the general body weakness she had. Her expectation was to get well, and the impact of this illness was that she was unable to work. So now summary after the history. AH, a 25-year-old female with no non-chronic illness, has been unwell for the past 1 year with a history of progressive general weakness associated with low-grade fevers, joint and muscle pains, weight loss, and a 2-week history of hypopigmentation of the skin involving the face, trunk, oral sores, and photosensitivity. And she also reported a prior history of convulsions and body swellings. However, she didn't have any history of polydipsia, polyuria, or heat intolerance. So after our history, our primary diagnosis, after all the symptoms that she presented with, we came up with a primary diagnosis of systemic lupus erythematosus in view of, one, the general body weakness she had, the joint pains, the oral ulcers, the photosensitivity, the convulsions, and the skin rash, as we shall see in the pictures that are ahead. Then our differential diagnosis was, one, we thought it could be a dermatomyositis. Why? Because of the skin involvement, the muscle pains, and the weakness. Then we also thought of a mixed connective tissue disorder because of the joint pains, the muscle pains, and the skin involvement that she had. The third differential we thought of was thyroid disease in view of the weakness she had, the fatigue, and the dry skin. Then we also thought of Behçet's syndrome. Why? Because of in view of the oral ulcers, joint pains. Behçet's syndrome is also one of the chronic autoimmune inflammatory diseases. They'll talk about it. The subsequent presenters will talk more about it. Then we went ahead to do a general examination. She was sick-looking. She was a sick-looking young lady. She was febrile with a temperature of 36.5 degrees Celsius. She had low mood with a dry skin. The other significant thing was the hypopigmentation that was involving the face. On the face, it was the cheeks, the forehead, and the anterior part of the chest and the upper part of the back. She also had alopecia. She had alopecia with no oral ulcers at that time, no genital ulcers, and no digital clubbing. However, she had bilateral pitting edema of grade 2, but there was no, I beg your pardon, she had bilateral pitting edema grade 2 with mild pallor. However, there was no lymphadenopathy, there was no cyanosis. And the other thing on the general exam was she had tenderness in the proximal interphalangeal joints, but there were no swellings on the joints, and there were no joint deformities visible. Yes, that's the picture. I think you can now appreciate the hypopigmentation on the face, involving the cheeks, the forehead. Then you can also see there's some parts of the upper chest that couldn't be exposed as that in this picture, but on the foreback we can see it clearly. And we can also, if you can see from that point that the skin is dry, I don't know if you can see it from there, but On the picture here shows the skin is really dry. Then on the respiratory exam, went ahead to do systemic exam, the systems we thought could have been affected. The respiratory system, on inspection, there was a normal respiratory rate of 17 breaths per minute with no signs of respiratory distress. She had a central trachea, normal chest movements, and expansion on palpation. The percussion notes were normal. Then on auscultation, she had bronchosvestibular sounds, breath sounds, which were normal, and she didn't have any other added sounds. On the cardiovascular system, she had a normal pulse rate of 68 pulses per minute, which were regular and synchronous. The blood pressure at that time was 110/72 millimeters of mercury, and she didn't have a raised JVP. Her apex beat was at the 5th intercostal space on the mid-clavicular line. Then further on auscultation, the heart sounds 1 and 2 were normal, and she didn't have any other added sounds. Then on the central nervous system, she had a GCS of 15. The pupils were equal and reactive to light. She had a soft neck with a negative kerning sign, and she didn't have any other craniopathies. Her motor sensory exam were all normal. Furthermore, the coordination was also a normal one, and also a normal gait. Further on the upper abdomen exam, there was moderate distension. Then on palpation, she had there was epigastric tenderness and shifting dullness. However, there was no hepatomegaly and there was no splenomegaly, but her bowel sounds were normal. After our exam, the primary diagnosis, we maintained the systemic lupus erythematosus. Why? Because of the weakness, the joint pains, the oral ulcers, the photosensitivity, convulsions, and the malar rash that she had. Malar rash is that rash she had on the cheeks and the cheeks basically. Then other differentials, we still maintain the dermatomyositis because of the same reasons, the skin involvement, the muscle pains, and the weakness. Then we also still maintain the mixed connective tissue disorder because of the joint pains, the muscle pains, and the skin involvement. The thyroid disease was also still maintained because of the weakness, fatigue, and the dry skin. Behcet syndrome was also maintained because of the oral ulcers and the joint pains that she had. So after our examination, we had an investigation plan. One, the investigations we thought of, or we requested to do were, one, the CBC. We also requested for peripheral film comment, the HIV screen, the ESR, the CRP, the renal function tests, the liver function tests, the urinalysis, then an autoimmune screen. Under this, we are looking specifically for the anti-nuclear antibodies, then the anti-double-stranded DNA antibodies. We also requested for an ECG and an echocardiogram, then also a thyroid, the TSH test. After that, the results that we had from the CBC, we had, these are the parameters that we noted. On the one, she had a leukopenia of 2.4. That is low white blood cell count. Then she also had a mild anemia of 9.4 grams per deciliter. Then her mean corpuscular volume was normal, lying between that range of 80 to 100. Then she had a thrombocytopenia of 96. That is far much lower than what we expect, what the normal range should be, of 150 to 450. Then the peripheral film comment showed red blood cells. The red blood cells showed marked hyperchromasia, anisocytosis with target cells, elliptocytes, teardrop cells, acanthocytes, macrocytes, and microcytes. Anisocytosis is basically red blood cells having different shapes and sizes. Then from the renal function tests and the liver function tests that were done, the AST, that is the aspartate aminotransferase, was at 281. That was very high compared to the range of 0 to 40. Then the alanine aminotransferase was at 43. That is slightly more than the upper limit of 40. Then she also had a mild hypoalbuminemia of 3.15. The normal range is 3.5 to 5.0. The direct bilirubin was at 0.74 milligrams per deciliter, and this was normal. The total bilirubin was high, more than the upper limit of 1.2. It was 1.59 milligrams per deciliter. High urea levels were normal, 21.3, lying between 10 and 50. Her creatinine was also elevated. Creatinine levels were elevated. She had a 1.41 milligrams per deciliter. That is slightly higher than the upper limit of 1.1. Then on the urinalysis, the leukocyte esterase was significantly elevated. As you can see, the 3 pluses that are there. However, there was no reference range here. There are also the ketones, the nitrates, the urobilinogen, bilirubin, glucose, and the proteins were absent. The specific gravity of her urine was 1.00, which is normal. The pH was also normal, 7.0. The blood, there was no blood cells that were seen in the urine. On microscopy, pus cells were significant. So you can see the 3 pluses. But ideally, the normal here is supposed to have at least less than 5. But the 3 pluses show that it was significantly high. Then on the other tests that were requested, her HIV test was done and it came out negative. The C-reactive protein was less than 5 milligrams per liter, which was normal. The erythrocyte sedimentation rate was significantly high at 147 millimeters per hour. Then the TSH was normal, 3.1. Then the anti-nuclear antibodies, you can call it the ANA. The titers were positive, that is 1 to 640, way higher than the reference of 1 to 80. Then the anti-double-stranded DNA antibodies were absent. Sorry, the test came out negative. Then the anti-Smith antibodies, the test was also negative. So after the history, the physical examination, and the investigations that we carried out, we concluded that this lady had a systemic lupus erythematosus because one, the multi-system involvement of that included the joint pains, photosensitivity, convulsions, oral ulcers, skin rash, and an elevated ESR and a positive ANA test. After that, we did some management. The first and foremost was to inform this patient and share about the diagnosis, because prior, when we asked her idea of the illness she had, she thought she was bewitched. So we wanted to take away that perception of being bewitched. So we have to inform her about this condition. And we also gave her as you can see, prednisolone, starting with 40 milligrams OD for 2 weeks, then tapered to 20 OD for 2 weeks, and again tapered lastly to 10 milligrams OD for 2 weeks. Then we also gave her hydroxychloroquine tablets, 200 milligrams BD for 1 month. Then omeprazole capsules, 20 milligrams OD for 1 month were also given to her. And she was also referred to a rheumatologist for further management. That's the history that we had. If there are any concerns on the history, maybe you can raise up any inquiries.
So thank you so much. You're not yet a doctor, are you?
You.
Mr. Doi, thank you so much for the wonderful presentation. As you can see, that's how the patient came to us. Maybe before we elaborate more about the case, do we have any concerns, any questions? Don't fear, even if the question is not very bright. Please ask. Please ask the question. And they are directed to Mr. Doi, isn't it? Yes, Francis.
Okay, my only concern was how you reported HIV status, such that there are unreactive viral the patient has gotten it inside like one. Sure, you have not been able to get it.
Okay. Mr. Doi, what is your reaction?
It's very right, but yes, he's right. It's very good that patient would have contacted it previously in the test. And normally there's a window when someone acquires a virus. It takes some time for the test to come out positive. So I think we can rectify it. Thank you for that observation.
Yes, Monica.
I have 2 questions. One, I didn't clearly get, okay, I know that it's, to a certain extent, idiopathic, but I didn't clearly understand the risk factors for the SLE in this patient. And then 2, I didn't understand what more the rheumatologist was going to do that you couldn't manage to treat.
Okay. Yes, Prof. You can go ahead.
Thank you for an excellent presentation, very detailed history, but I suspect my attention was not 100%. I did not hear you mentioning particular drugs, that there was no history of taking this drug or the other one or the other one. Which would those drugs be which might precipitate SLE?
Yes, Mr. Doi. Which drugs?
Maybe I can answer them at the end.
Okay, that's good. Yes, Ibra.
Thank you very much. Mine is at the end of your physical examination, was at the end you gave us your differential, your diagnosis and differential. You had maintained the other ones, which is okay. But during your examination, you had some findings, and I did see you incorporate these into your diagnosis and differential so that you maintain them. Because you had some findings like shifting dullness, epigastric tenderness. This was when you came at that point of giving us the differentials, you still maintained the other symptoms, which is fine, but I think also fitting in the positive findings in physical exam. Thank you.
Okay, Mr. Doi, have you written them down? Yes. Yes, a call.
Good evening. Good afternoon, everybody. When you were reviewing the past medical history, when you reached on the chronic illnesses, I wanted to inquire from him why TB specifically is one concern.
Okay.
That's why you have to rule out TB from there. Before you TB approved.
The other thing is related to what Professor said. Professor asked about certain drugs. So one of those drugs is isoniazid. Yes, so if a patient has been on isoniazid treatment, isoniazid is one of the drugs that is known to cause what? SLE. That is also the other reason why we are so much interested in TB treatment.
Now, Joseph.
Yes.
Everybody talks about night sweats. Who does not sweat in the night in Sorority? Except maybe last night. But I want you to add excessive night sweats.
Okay.
Evidence of which is your sheets are find them wet.
Okay.
Excessive, don't just say night sweats. Because everybody sweats.
Okay. Thank you for that correction.
Okay, yes, Jimmy?
Thank you so much for your presentation. My question is just about the data. Okay, I want to understand what is the rationale to find out the single test that are put the rationale in this test. Maybe agree to take the forthcoming personality disease to give so much pages to this. Why the tests were done and why we why we
Okay, just for some of these tests that were done, this disease is a multi-system disease. It affects, I think on the pathogenesis it might come out clear why some of these tests were done. One of the, maybe I can come back here a little. Okay. This, first of all, several systems are affected in this disease. The hematological system, the renal system, the and it is an autoimmune disease. So why we are checking for this ANA and the anti-dsDNA, we want to rule out a possible autoimmune infection disease. And as you saw from the results, the ANA came out positive. So it confirms that it's an autoimmune inflammatory disease. Then these other hematological tests, this disease has a significant impact on the hematological parameters. It also affects the renal system. That's why we are looking at we did the urinalysis. We want to see a possible, on the urinalysis, we want to see if the renal system is affected. Is there blood in the urine? Are there red blood cells in the urine? Are there white blood cells in the urine? If the glomerulus is affected in this disease, it will come out in the pathophysiology. You can have leakages of these cells into the urine. That's how some of these tests come out positive. As we said, it's a multi-system. Several systems are affected. Then, for the person of the Mutiaba asked about shifting dullness, it also comes under the same system, under the same thing, where multiple systems are affected. The GIT is also affected. You get? Where we have you have inflammation of the peritoneum. You get? When there is inflammation, there is leakage of fluid through the peritoneum into the peritoneal cavity. And that's how that shifting dullness comes about. You get? One thing we did was to look at all these systems that are affected and incorporate it into get a diagnosis that fits all these things, all the symptoms. It may not come out clear now, but the subsequent presenters will make them clear. Our doctor also said the drugs he mentioned, there's what we call drug-induced SLE. And one of the drugs, as he had mentioned, rifampicin, isoniazid, sorry. Yeah. Then for the risk factor, it will come out. Yeah. So I think without wasting much time, let the program flow.
Okay, do we have any other concerns, questions? Monica asks, what is the purpose of referring the patient to what? To rheumatologists. Do you have any answers?
I think, there are things possibly we could have missed out as a student, first of all.
Now you're a physician.
Then, we refer to other people to see for further management. We couldn't have managed the patient better, but we did what we could. The rheumatologist would do better. We suspect and expect the rheumatologist to have more. Basically for further management in case.
Yeah, so the other reason is, in this country we run what we call registries. I'm sure you've heard of the cancer registry. So for conditions such as these, we don't have enough literature from our setting. So we want, and we know there are some people who are specialized in rheumatology, and we believe that they have a high volume of patients that they are seeing. So one of the reasons is that we want this patient to be recorded in our systems. And many of these patients, we see them, they go home, and you never see them again. So for follow-up, that is one. Secondly, the drugs, as you will see, are very expensive. And there are some people who have connections to suppliers who sell relatively cheaper what? Medicines. So by connecting them to these people alone can help to improve their quality of life through provision of care, because many of the drugs we use are not here in Soroti, apart from maybe prednisolone. Many of the drugs are elsewhere. So much as there may not be much that is going to add, but it helps to capture this case, and it also helps with the linkage to pharmacological care. Yes?
Someone is fascinated to have the patient being treated for malaria, and there are some improvement. Like we suggesting that there's a benefit of malaria treatment in the condition. And if so, drugs are used for malaria.
Okay. Mr. Odo, you have written it down? Yes, Dr. Muhind.
Thank you very much. In the social history, there was the part where you said what idea did the patient have about their illness, and the patient thought she had been bewitched. In your management, I don't know if you used to tell us, but how did you address her fears and her concerns and her ideations about her illness?
Okay. Let's first give chance to Crichton here. Yes, Crichton.
I don't know whether I was surprised about the patient. Because according to his history, there are so many pulmonary diagnoses.
Okay.
So, I can even say rheumatoid arthritis because the patient is
Okay.
So, why did we choose those differential diagnoses? And also, in part of management, is this a patient who like to refer to the dermatologist?
Beg your pardon?
In part of management, it's a kind of patient who refer to the dermatologist.
Dermatology.
Okay.
Yes, Francis, go ahead.
Yes, please.
Not only because of my eyes. I thought that rash was not about rash. My lecturer of economics who appeared to be there. Bala rash is usually a rash, which is more like discoid. And usually it affects the cheeks and spares the nasolabial. That is what I remember. I looked at that presentation and it seemed to be affecting the nasolabial. Can I say, books don't, conditions don't read books?
Exactly, I was going to tell you that. No. I was going to tell you the same thing, that diseases don't read books. But when you looked at the picture there, this was so typical of the malariash. Just that the involvement of the forehead maybe might have masked or something, but it was so typical.
We can see.
Thank you. Can I just add something small about the concerns of referral? I think one other small reason is that this lady lives in Kampala, works in Kampala, and the rheumatologists are there. So why not? I mean, it's not so much of an inconvenience. She will not fail to reach him. And this clearly is a chronic condition, and it's just as well to have another hand helping or supporting the management.
Okay.
Thank you.
Just one more thing. Someone asked about why I didn't put rheumatoid arthritis. He's right, it's one of the differentials. But from my history, rheumatoid arthritis normally is associated with stiffness of those joints. and the swellings, but as of this patient, there are no stiffness of joints, of the affected joints. That's why I didn't include it there. But he's right, it could have also been a differential. Okay? Then doctor asked about addressing the fears that this patient had, that she could have been bewitched. I think I did elaborate more on that, but somewhere we had talked of dissemination of the information and telling her more about the diagnosis, just to take away that perception. After the tests and all the examinations and the history, and it came out that it was after all that, it was so typical. Everything was driving towards the SLE. So it was totally right to sensitize this patient and tell her more about the disease, and just to take away that perception that she was being bewitched. Maybe it didn't come out well, but somewhere there it was mentioned. Yeah. Then someone talked of the drugs. Stephen asked about, previously she was treated for malaria, but the previous episodes were treated as malaria, but with minimal improvement. First of all, I should have noted down the malaria treatment she was having. It was not indicated there. But as some of you might be aware, hydroxychloroquine is an antimalarial, and it is significantly, and it is very important in the treatment of systemic lupus erythematosus. It has good prognostic features when used in treatment of this disease. I just didn't get from the patient the drugs that she was being treated with, but I should have noted it down. Okay. Any more inquiries?
But also the other reason is that many times patients have other infections like a UTI, and in many of our clinics we usually get a cocktail: antimalarials, antibiotics. Sometimes they even add dexamethasone if you have been to them. So it is not surprising that she reported some improvement after being treated for what she was told was malaria. But as he said, we should have inquired further to find out which treatment exactly she received. But our hypothesis is that probably she had a steroid in there for some time, or she had another infection for which she received antibiotics. Because at this presentation, she had a UTI as well. So that is what we thought could have led to the improvement. Any other concerns? Yes, Professor Kiria.
Yeah, I'm so unlucky that I've come late. So there is a lot I missed.
Yes.
But I know I'll catch up along the way, and help me catch up. I see on that photograph displayed involvement of the nasolabial folds.
Yeah.
When does SLE dermatopathy involve the nasolabial folds? And asking for my neighbor, what is the past obstetric history of this patient?
Yes, Mr. Doi.
These are very nice questions. First of all, just to start with the past obstetric history, it would have been so important to find out the past obstetric history of this patient, but unfortunately, didn't find out, didn't ask. But it would have been important to ask.
So you are saying it is a major omission?
Yes.
Yes.
Agreed?
Yes.
But in case you have the opportunity to ask, what would you have asked?
I would have asked her for previous histories of miscarriages, if she had.
Yeah, so
basically miscarriages.
Things like preeclampsia, in case she has ever had a baby. So,
yes. Yes. Okay. All right. Then Professor asked about, thank you,
the rash.
You came in after someone had raised a similar scenario.
So it's a common concern.
Yes, it's a common concern.
So, but
okay.
Some of those will be answered as we go along.
Yes.
But just to preempt the discussion, the SLE can present as acute dermatitis, it can be subacute, it can be chronic. So the chronic forms, as you move from the acute to the chronic, the patterns tend to disappear because no one is really aware of when this rash actually started. Even the patient themselves do not know. And another thing is that sometimes patients get superimposed infections on top of, the original rash. Someone gets a tinea, sometimes they get bacterial infections, and it disfigures the so-called mother rash. Huh? Yes, and maybe this is a different presentation in the African population. Maybe. So at this point, we cannot really conclusively say it is not a mother rash. It looks like it, but it's not what is described in the books. You can see this rash is involving the back. It is very uncommon with things like SLE. So there are many hypotheses around this rash. And that is also one other reason why it is important for the rheumatologist to have a look. If you saw in our differentials, we had something called mixed connective tissue disease, where you have features of SLE and what? Francis, you have finished rheumatology. What is mixed connective tissue disease? Anyway, so you have features of SLE and systemic what? Sclerosis. So we could be missing something like that. We might be focusing on SLE, yet this is mixed connective tissue disease developing. So there are many reasons for why this rash is not typical, but based on the other evidence, we felt that this is most likely SLE. We did not invest.
Yes, Mark, but also, how have her clothes been? Has she been exposed in the back? Because she's a beautician of some sort, isn't it?
Yes.
She might be exposing her back to the sun.
Yes.
And as a process of photosensitivity, that rash can start on the face, must expose the sun, and then it can go to the back if she has been exposing the back as well as the chest. So.
Thank you, Professor. That is very plausible as well.
I wanted to chip in something about UTI. Many people make a mistake about UTI. UTI, for all of us who are here, you must demonstrate multiplying organisms, pure growth in the urine. Pyuria or 3+ is not UTI. And I'm just trying to look up, does cystitis per se occur in lupus? Yes, it is one of the manifestations. So you can have it as sterile pyuria. It's one of the causes of sterile pyuria. So UTI, define it properly. Don't accuse a presence of 3+. That urine could have stayed in the bladder forever, and it's just 3+. It might have been even scanty or 1+. If she was passing urine, drinking continuously.
The other thing is, I don't know whether we tested for sensitivity in the hypopigmented areas. Because I'm thinking of leprosy as a differential. Many people who are here may not have seen leprosy. They are too young to have seen it. But there are new cases of leprosy being reported in Uganda today.
Yes, she did not have loss of sensitivity. She also didn't have swelling of any peripheral nerves on exam. So it's still a differential, but unlikely. And of course, definitely leprosy could not explain the other presentations that she had. But it's still a big differential as well. So any other concerns?
Maybe Joseph might have wondered, I don't have an answer. Why was the CRP normal and the ESR high?
Yes, ideally, in SLA, you'd expect the ESR to be elevated and the CRP to also be elevated. When I was looking through those results, I questioned somewhere, like, something wasn't clear, but you're right.
So, guys, about 50% of patients with SLE have a normal to mildly elevated CRP. So it's not a must, because remember, CRP is an acute phase what? Reactant. So if you've had chronic inflammation, it dips over time. And it has been reported in some patients. They have normal CRP with a very high ESR. It's not really surprising. And in fact, literature says that even if it's high, it never goes above 50. It is just mildly high.
But this one went above.
No, this one was, no, I mean the CRP was normal in here. The major surprise would have been with the ESR. Had it come out normal. All right, any other thing?
Had it come out normal, one would have to see the heart. Sometimes when you get heart failure, your ESR might go to 0. I don't know why, but it could happen. But if there are a lot of people here, please, the old time ESR is still very important from this patient. I have seen the lab technicians putting that aside. Some labs do not have even those special green tubes. And yet they are easy. Okay, they may break them frequently, but every lab should have ESR examination.
And for that matter, our students do not know the units for ESR. Let me see who knows. Can I do that random? The one who's looking behind.
Not like it's meals per hour.
Meals?
Millimeters.
Okay.
It is millimeters per
hour.
So that means I can say I can do it over 2 hours and divide by 2, or do it for 30 minutes and multiply by 2.
In 1 hour.
You see what I said? Because we don't do it, the students do not know the units for ESR.
Oh, power is off, eh?
So you are
Professor, I beg to correct it.
do so.
It is millimeter in 1 hour.
In the first hour.
Unfortunately, when they are cotton, they actually put that slash. That's wrong.
Yes, they put slash.
That's the wrong unit.
They put slash. Okay, maybe before we continue, I think Professor Kiria and Dr. Dale, you're welcome. And I think you should come and officially open again before we continue. Okay, Professor has agreed that we continue. So let's hear from Dr. Yahaya, who is going to be telling us about the pathogenesis.
Yes, there's a computer here. This is the microphone. So
you can put it here and speak through the microphone. Be like this. You don't have power.
That's what I have asked him, but he's saying we can. Yes?
No, even this will not work without power. Maybe we call it difficult down.
Yeah, it is already there.
I think we'll get some from you can't control. It is not battery to start the generator.
There is no one? Ah. Yeah, I think I can present from. Yeah. I don't have even pictures. I have only the sentences.
No different from being in Capella.
I'll just, is it on? Yes. Yeah, it is on.
Okay. So
yes, good afternoon, everyone. When it comes to SLE, that is about the way how SLE develops. It is very complex, and there is no single solid statement or explanation that can clearly explain what exactly causes SLE. And literature shows that the knowledge, the understanding concerning pathogenesis or pathobiology of SLE is very dynamic. So many schools of thoughts have been brought up or raised from different angles across the globe, trying to explain what exactly causes SLE. However, there are some common or general explanations that can back up our understanding concerning pathogenesis of SLE. And that's why you have heard of the use of corticosteroids as an approach of managing cases or patients of SLE, so that to try as much as you can to modify the immunity of the patient, because the hallmark of SLE is inflammation. Is inflammation as a result of formation of autoantibodies. That is how you can summarize in a simple understanding, but there is no one that includes me here today. I'm not going to be in a position to satisfy every person here who might ask a question concerning what exactly SLE. So they are about three key important points that can help you to think of what might be behind the SLE. One of the key issues in the SLE causation of pathogenesis is the failure of self-tolerance. Is the failure of self-tolerance, and because of that, there is activation of autoreactive T and B cells. So that is what happens. And now, when you mention of autoreactive T and B cells, definitely you are touching on the role of adaptive immunity in the development of SLE. So, in the pathogenesis of SLE, we consider both innate immunity and adaptive immunity. Now, if you talk of activation of, if you talk of failure or loss of self-tolerance, the next question will be, what causes that? What causes that? Most of literatures try to highlight that we have what we call, we have a subgroup of individuals who are susceptible to developing SLE. And these are the individuals with the mutations, particularly in the MHS gene. And from different sources of literature, you find that up to 30 loci have been identified within which there are mutations in the MHC complex. such individuals are very prone to getting failure of self-tolerance, leading to formation of autoreactive T and B cells. Another possible explanation is on the issue of cell damage, which could result from environmental factors. And she chipped in asking the first presenter on what could be the risk factors. So it's about environmental factors, and one of the commonly implicated environmental factors are viruses. Some viruses, for example, EBV, has been found to contribute to some extent to the development of SLE in view of causing cell damage. So when there is cell damage from environmental factors, the immune system is exposed to self-antigens. Again, that again leads to activation of the T and B cells. And we have seen when there is auto-activation of the T and B cells, we should expect a high possibility of development of autoreactive antibodies. So the third possible mechanism is about the innate immune responses has been found to be aberrant in patients with the SLE. And there are a lot of explanations concerning the role of innate immune responses for the development of SLE. One of the explanation about the role of innate immune is for the production of some inflammatory mediators of inflammation, particularly interferon alpha, that has been so much associated with the problem with the innate immune system, and that also includes issues to do with the dendritic cells. For example, there were some researchers previously who conducted a research trying to look at the role of dendritic cells in the development of SLE. So they had to go in and do what they call gene knockout for that particular cell, and then have the controls and follow up that particular cohort, and they found that for cases they were able to develop SLE. So what have I said? I have said about the issue of loss of what? Of self-tolerance, and that comes in particularly for individuals who are susceptible as a result of mutation in their MHC complex. You know, the MHC complex has got a lot of genes with different loci, and so far, as I've said, six of the genes have been identified to be associated or linked up with development of SLE in the 30 loci. Now, when you continue amplifying the understanding concerning the adaptive immune system in the causation of SLE, there is involvement of the TLR. This is the TLR. This is a receptor, and the involvement in the development of SLE is considered in two different ways, as a dependent pathway, but also as independent pathway. Now, still the explanation is the same, that with the TLR dependent pathway, we have the TLR 2, 4, and 6. Once they are activated following exposure to extracellular DNA or RNAs, it could be DNAs from within the individual, or DNA or RNA from outside sources. This is from environmental factors, for example, infectious agents. So that causes dying of the cells, and again, once that happens, there is what is called the activation of some pathways. For example, interferon regulator factor 3, but also there is interferon regulator factor 5. Then we have the nuclear factor kappa B, but also we have other pathways like the mitogen activated protein kinase. Such pathways, once are activated, what happens is that they trigger release of a number of chemical mediators of inflammation. And now you get to understand that the cytokines, for example, the interferon alpha, the interferon gamma, these are the ones that contribute to tissue damage, because the previous presenter, based on the literature that you have been reading through, is that this is a multi-system organ, and it causes multi-organ failure. But what exactly causes the failure of more than one organ in any individual with SLA? The story goes by saying that it's about inflammation. So what should concretely be blamed in SLE is inflammation. And that is why a number of drugs, a number of pharmacological agents in trying to treat patients with the SLE, they target either to suppress, first of all, to suppress the immunity. When you are suppressing the immunity, ideally you are modifying, you are conditioning the body that it should suitably respond to the chemical mediators of what? Of inflammation. Otherwise, if you have exacerbated inflammation in the case of SLE, you should expect fetal clinical outcome. Concerning the TLR pathway, when looked into in an independent way, there is endosomal TLR. These are receptors. Again, once they are activated by, for example, a single RNA or demethylated DNA, that again leads to interferon alpha production, RNA binding autoantibodies, for example, Rho, La, SIM, and RNP. So, as you have been raising a lot of questions concerning this case, whether it is SLA or not, it is very hard to draw conclusion based on the Mara rash, based on, even if it is multisystemic disease, there are a lot of pathologies that you can clinically go with involvement of multisystems. So I happened to have some discussions somewhere concerning SLE cases. And of course, in Tanzania, so far, there is a society for cases or patients with SLE. That is called the Lupus Tanzania. You can go into the website and try to check. In Tanzania, when a case is suspected to have SLE, we are so much concerned with examining the kidneys by doing percutaneous renal biopsies and see what can be happening in the kidneys. So, to summarize what I have said is that is about inflammation. Inflammation begins with the and we never know, like in this case, this is what for my students, I've always been telling you that we have reached a point where there is no way you can keep on running away from molecular studies. Now, this is a typical case where one can go in and look at the MHC complex for this individual and see what could be happening in terms of the genes for this particular patient. Another current idea which they are looking at, apart from the innate immune, apart from the adaptive immune causing production of autoantibodies as a result of dysregulation of the TLR receptors and the like. There is a current school of thought, the so-called NETosis. I don't know if you have come across any one of us here. NETosis, N-E-T. This is a nuclear extracellular trap. So they are trying to look at it and see if it can be responsible for causing SLE. Again, even in NETosis, the same story, that as they continue exploring it, but they are coming to a conclusion that it causes activation of inflammatory factors. So we just go back to the old thinking. So whatever I said in summary, that is SLE is a complex disease, and there is no single explanation that can address, and that is why, because of lack of that, even there is no single specific management that can be employed and in most cases, patients with SLE, I have encountered like 2 doctors, specialists in Tanzania, who died of SLE. So that is in a nutshell about pathogenesis of SLE.
Thank you so much, Dr. Yahaya. Thank you. I think it's okay to give him another hand clap. As he said, it's very complex, but maybe we shall have someone from this group to simplify, isn't it? Through research, as Doctor said. We could do some more research. Eguyu there looks so that we stop calling it complex. Maybe there is that wonder gene that we can find. The world is now talking about gene therapy. Have you read about that?
Yes.
Not you, Professor. So maybe we shall have some treatments that target the genes that Dr. Yahaya talked about. But thank you so much.
You're welcome.
We are sorry that the power is not on, but we shall move on either way. All right. Do we have any clarifications, something that is itching you about the pathogenesis of SLE? Yes, Jimmy? Please go ahead.
My question is why? It's just more given the fact that we actually have behind several drugs that are in the market and they actually being the culprits inducing drug-induced SLE. So I wanted to understand, has there been any studies done to understand which moiety in these pharmacological agents that is actually leading to the pathogenesis of SLE? And also, in relation to our previous discussion, pertaining several mutations in the gene loci, I wanted to understand which one exactly is affected.
Thank you, Jimmy. I think I'll let Oda answer the first one. Oda, you said, I remember you talking about what he asked. He's asking what exactly happens when the drugs cause SLE.
It's also not exactly
Acetylation.
So
Eh?
if I told you it's not acetylation, it's clear it's also reviewed.
No, I think that's okay. So basically the drugs that follow the N-acetylmethylation pathway, isoniazid, prokenamide, and many others. Eh? Yes, but it all comes back to what Dr. Yahaya was talking about. Please, the second question. The first one, I wanted him to answer.
I've not gotten his question clearly. Is he asking of specific genes mutated?
Yes, yes.
The literature does not speak clear of specific genes, apart from mentioning the MHC complex. Yeah. Although I'm not denying that, literature is wide. It depends if from which angle you're reading. But again, I would just remain skeptical, like what you tipped in, that if there would be specific genes, those could have been the source of targeted therapy. So that means there is a possibility that there is no yet identified specific gene. Yeah, because the world of today is talking of targeted therapy. Yeah, so, and if you have multiple genes that SLE is a polygenic disease, meaning that it is not a single gene that, even if it is mutated, can cause. But very few literature which mention that there are very few cases of SLE which are monogenic, but the majority are polygenic, implying that there are many genes that come in the causation or development of SLE. Unlike other diseases, for example, sickle cell disease, where you have a specific mutation in which you can go in and target it. Yeah.
Yes, Professor Ki.
Dr. Dere is asking me to ask you.
Professors are here. Yes, please.
The role of the X chromosome. He says he thinks SLE is like a man. It falls in love so much with the X chromosome. The more X chromosomes one has, the higher the chances that that person may actually present with SLE. If you see women with triple X,
have increased the risk.
yes, and then people with Klinefelter syndrome, they actually carry more chromosomes. than the other population.
Yeah, whatever you said here, just mark that SLA is a complex disease, so. You see, Professor, I have been telling our students that they should not be saying that there is no employment. Now look at SLE. There is no specific therapy for SLE. If you can go in and come up with a proper treatment for SLE, you will always be employed anywhere across the globe. Yeah.
Yes.
So if there's a gene involved, it's most likely X-ray.
Well, it would be more in the males, but we know that the MHC is carried on the X chromosome.
Yeah.
Yes, and then there is also the element of hormonal. Yes, there is especially estrogen, and it is believed that the estrogen receptor is very similar to the B cell receptor. So during times of, is that called menarche? Kindly remind me.
It's called menopause.
No, when you produce, I think it's the childbearing age. Yes, during the childbearing age, you have a higher concentrations of estrogen swinging up and down. And as the doctor said, it is hypothesized that some of that estrogen activates B cell receptors, resulting into an increased production of auto antibodies. It is the same explanation given for rheumatoid arthritis and all other autoimmune diseases, which are common in what? In females. Huh? Yeah, but there is no single bullet. It's a combination. Yes, do we have any other concerns? We are really sorry we don't have, it would have been nice for us to see the pathological slides, you know, post-mortem or biopsies of a patient with SLE. Dr. Yahaya, have you collected some in the department?
You mean images or the real slides?
Yes.
Yeah, we don't have. Have. But I can get them.
Okay, so maybe as we share the presentation along, it would be nice to share them as well for the students. Okay, any other concerns, questions?
Yeah. Maybe as I wind up, that SLE, you think much more like, of course there are many organs, but like what we have seen here, the kidney, the creatinine, and some RBCs in urine, that has to do with the more of glomerulonephritis to the kidney, and it can be graded from 1 up to. So yeah, that's why with SLE you think more of doing percutaneous renal biopsy to examine the kidney. Yeah.
All right. Thank you so much.
Thank you.
Another. Professor Diet, do you have any words of wisdom before we go to the next presenter?
No, I think it's a very complex disease. My simple question to Joseph was, can you just count the systems that are involved in our patient? Just 1, 2, 3. I think they reach 5. Don't you think so? Yes. So which were they?
That's the renal system.
The kidneys were involved.
The skin.
The central nervous system.
The CNS was involved because of the convulsions.
The hematologic system.
Hematology. Musculoskeletal. Yeah, so I really want us to appreciate especially what you can see. And not, it's complex, but there are certain things that you can see. Those ones, don't forget them. Because what these people presented shows that this patient has been through hands for years, and no one actually labeled her possible SLE until it came to the wise hands of Joseph, his teacher, and we are privileged to discuss the patient today. So it is very, very serious. Gives us very few marks in terms of our clinical acumen. We who are practicing clinicians, not yet for you, the undergraduates, because it is us who are in the fray. But I hope you plug this. When a patient comes to you, do your best. And for SLE, this may be the final, as I said before, this may be the final discussion before you meet the patient of SLE or before you actually are examined on SLE. I myself said a question from the patient. I was running a renal clinic, and this child just comes with nephrotic syndrome. And then the kidneys also fail. Of course, if it's just obvious nephrotic syndrome, you are happy to manipulate things. But the kidney also failed, and the failure became worse and worse. The father was posh, pressed me to send the child to India. We sent the child to India, lo and behold, biopsy, as Dr. Yahaya was saying, biopsy, SLE. They started medicines that I had in Kampala. So I felt like a fool. So it is as serious as that. Thank you very much.
Thank you, Professor. So I'm going to take us through the epidemiology of the disease. All right, so I'll go straight to the point. We know it's a complex disease, and probably that's why it is the whites who are reporting it more than us, because they pay more attention to detail. People here don't want to pay attention to what? To detail.
You don't want to read.
Yes, so the prevalence is much higher in North America and the Europeans compared to the what? To Africa. And we think that one of the reasons is because of missed diagnosis. There are very many patients who we miss on our day-to-day clinical care. We see that it affects women of childbearing age in that ratio of 9:1. We have been here trying to hypothesize why. But when it happens in a male, it carries a worse prognosis. And it deteriorates quite faster compared to the female. How does it present? We have already said it's multisystemic, so you can begin from whichever system you want. Musculoskeletal to CNS, to hematology, to GI. And by the way, some of these patients present in the psychiatric ward with psychosis. So do not label people psychotic. Investigate for organic causes. So musculoskeletal, we have seen this patient had some form of arthralgia. Patients may present with overt arthritis where there is swelling and pain and stiffness. It may be just the myositis which causes muscle pains. Patients may present with central nervous system manifestations, and these range from neuropsychiatric, such as major depression, psychosis. They may present with seizures. This patient had convulsions, so status epilepticus, or even a one-time fit. Patients may present as stroke. There is something called stroke in the young. If someone is below 60 years, no cardiovascular risk factors, and is presenting with a stroke, think about SLE. Patients may present with peripheral neuropathy, which usually tends to follow what we call a gloving and stocking distribution. Pins and needles involving the hands and the feet. Or it may just be a mononeuritis. Someone just comes with a painful, nerve root, and you see they complain of pain along the course of that particular nerve. It may present as transverse myelitis. Young female, I think someone discussed the case. There is a young female in surgical ward with paraplegia from nowhere. You need to investigate for SLE. Cardiovascular system patients, usually because of inflammation in the pericardium, they tend to present with the features of pericarditis, but they may present as an episode of infective endocarditis, which we call Lindman-Sachs endocarditis. Patients may just present with heart failure from some form of subacute endocarditis that we have not diagnosed, and they are coming in with heart failure for which the cause is unknown. Sometimes patients may present with the more complex conditions like aortic dissection as a result of SLE-related aortitis, inflammation of the aorta, resulting into dissection. In the GI, I think we talked about the oral ulcers. Patients may have pancreatitis. Patients may just have some form of colitis, and this may range from non-bloody to bloody. So you may actually think the patient is having inflammatory bowel disease, yet it's just a presentation of SLE. Of note, some of these patients, before they present like that, may come with an episode of acute autoimmune hepatitis with liver failure. They have no history of herbal medicine use, no alcohol use. They have been well because of autoimmune hepatitis. Pulmonary, it may just be a pleural effusion that has no cause as per the investigations. We normally tend to rule out TB, pneumonia, heart failure, common things. No cause can be identified. Think about autoimmune, SLE, interstitial lung disease, are very common. Patients present with progressive dyspnea and a dry cough and later respiratory failure with no known environmental factors. Renal, I think the renal has been emphasized. Renal. Sometimes patients actually may present with just lupus nephritis, like the case Professor Ditt has shared. So a urine dipstick is important to check for hematuria and proteinuria. Hematology. We see many patients with anemia that cannot be attributable to a cause. Think about SLE. SLE causes inflammation in the progenitor cells within the bone marrow. Some patients present with the thrombocytopenia, others may present with a pancytopenia. Dr. Deru emphasized the venous thromboembolism. We are going to see SLE is associated with production of some autoantibodies that increase the risk of thromboembolism. So, if someone gets what we call an unprovoked venous thromboembolism, an unprovoked venous thromboembolism is that occurs in a patient without a known risk factor. They have not been operated upon, they are not bedridden, they are not obese, they have no orthopedic cast in the recent maybe 3 months, and then all of a sudden someone comes with a PE. Think about thromboembolism due to SLE. Dermatological usually presents in those 3 forms. I think we had talked about it previously. We have the acute cutaneous lupus, which presents with a typical mother rash, where you have a rash around the cheeks that is sparing the nasolabial folds. I hope my picture is here. I'm going to show you. And then the subacute lupus erythematosus due to photosensitivity. And you tend to get a widespread rash. I think Professor Ditt talked about that. And then you may have the chronic lupus, which presents with discoid. Discoid is more like coin. Yes, there are other features that we should never forget. These patients have fever. So don't think every fever is equal to malaria. There are other things. Malaise, hair loss, weight loss, dryness. Zika syndrome is dryness, dry eyes, dry skin, dry saliva, conjunctivitis, intermittent episodes of red eyes all the time. Think about systemic lupus erythematosus. But remember, because of the complexity of the disease, we have to rule out other causes before we blame SLE for all the presentations. Okay, so because it is multisystemic, even the investigation is multisystemic. So you check everything from hematology to CNS, depending on the presentation. Hematology, we are interested in looking at the hemoglobin, platelet, white cell count, and I think our patient had a pancytopenia, if you remember. The complement system, in the pathogenesis, one of the other theories is the role of the complement, especially patients who are deficient in which complement protein? C what? C3, C4. Not really. It is deficiency of which complement protein? C1q, C1r. And that results in some form of consumption of the other complement levels. Patients may also have autoimmune hemolytic anemia, so we do a Coombs test to test for that. And phospholipid antibodies, these are the ones that assess your risk of thromboembolism. We shall see some of them. The renal, to assess for renal function, you need the creatinine, urea, protein in urine and red blood cells. Things like ECG, if a patient presents with features that are suggestive of cardiovascular disease, chest pain, palpitations, dizziness, body swelling, to mention but a few. But it would also be prudent for you to assess, even if the patient did not report because some patients have subclinical disease. So you do an ECG, echo, brain imaging is indicated for patients with the suspected stroke. A chest X-ray, it is important. It will help you to assess for things like interstitial lung disease, pleural effusion, and cardiomegaly. This is a table from the New England Journal of Medicine giving you some of the autoantibodies that are present and their significance. You can see that up to 99% of patients with SLE have a positive anti-nuclear antibody. But there is that small 1 to 5% who have a negative what? ANA. So not all patients with SLE have a positive ANA, but almost all. I think in medicine they tend to use words like uncommon. There is a way they confuse. Okay, because of that, the current definition is if you have multisystem involvement in a patient with a positive ANA, then you suspect SLE. Shall see the diagnosis. The next autoantibodies are very important for the obstetricians, and I'm happy Dr. Adelu is here. Anti-Ro, anti-Ra. People nowadays will ask you questions. Like this patient can ask, Doctor, I want to get pregnant. What should I be worried about?
First, the husband.
The husband. Okay. That one, the spiritual prayers can bring, but there are other things as a scientist that you can intervene in. Anti-Ro, anti-La, these autoantibodies predict things like neonatal lupus and the risk of neonatal congenital heart block. So you need to warn the patient about this if they are present. And you can see under timeline there that some of these antibodies may appear years before overt disease. And that has led to something called preclinical lupus. Nowadays there's something called preclinical lupus. So if you have some patients out there who are complaining of fatigue all the time, you are calling it stress. Do their ANA, you'll be surprised. It might be positive. Power is off again.
Again, it's AC, alternating power.
Okay. All right, so double-stranded DNA, this one is very specific for SLE, but it's only present in 70% of patients with SLE. And when it is present, it tends to predict a poor prognosis and also predict the possibility of having lupus nephritis. There are other antibodies, like Dr. Yahya talked about, anti-U1 RNP, which is also present in patients with mixed connective tissue disease. Antihistone. Antihistone is present in patients with drug-induced lupus. Drug-induced lupus is commonly induced by procainamide, which is an antiarrhythmic drug, hydralazine. The obstetricians love it so much, but we are seeing it causing lupus. Isoniazid, we talked about it. Okay, so how do we diagnose the disease? Of course, we must take history and do physical exam, and we consider a diagnosis if the history and physical exam are compatible. For example, if you have multisystem involvement in your symptoms, and this is where the students usually mess up. You tend to construct over 10 diagnoses. Joint pains in view of malaria. Enteric fever in view of abdominal pain. Then you mention another one, meningitis, in view of headache. So can you get something that explains everything, what they call the Occam's razor? Everything. Can you think through and find a diagnosis that explains the whole presentation of the patient? So the diagnosis is based on the 2019 European League Against Rheumatology and American College of Rheumatology criteria. And the important here is that for you to diagnose a patient with SLE, first of all, the ANA must be positive, and then the patient should score at least 10 points on the criteria which I'm going to share. So positive ANA plus a score of at least 10, then we classify that patient as having SLE. So this one looks at, the criteria looks at manifestations from all the systems. Under constitutional, we have fever, we have things like, mainly fever. If a patient has had fever, usually the patient is scored 2. Then hematology, they look at leukopenia, thrombocytopenia, autoimmune hemolysis, and the scores are, so you don't have to cram this because it's quite complex and big. I don't think that we shall ask it in the exam for you to reproduce this criteria. That is cram work. But the most important thing is for you to know the different presentations in the different systems. But nowadays there are even applications, you get your phone and put in for each fever, it gives you a score. And then it will give you a total score. But important to note is that things like seizures, things like renal biopsy, as Dr. Yahaya was talking about, renal biopsy showing lupus nephritis, carry higher marks. These marks were assigned based on literature review of the so many researches that were done. But as we were students, previously we used to use that mnemonic, the soap brain what? MD, which, who can summarize it for us very quickly? It is much easier to remember compared to the SCR criteria. Soap brain MD. S stood for serositis, which could be pericarditis, ascites, pleural effusion. Then O, oral ulcers. A, P, then B, R, renal involvement, A, then I, immunological disorder like a positive double-stranded DNA, then N, then M, and D. Yes, so the classification moved away from that because it was realized that it was less sensitive. It would miss out some things. And so that's why they developed that large criteria that helps to diagnose. But on the ward, we still use the soap brain MD. If a patient has at least 4 of the 11, we suspect SLE. Lastly, still about the diagnosis, things like for SLE-specific antibodies carry a higher mark, and then you can also do the complement proteins, as we said. If they are low, they carry a higher mark, and the antiphospholipid antibodies. So you can see that it is very expensive to investigate a patient with SLE. I know one nephrologist who can request for all these tests, and then a patient complains that they asked for tests of 4 million. But anyway, they are ruling out lupus nephritis. So that is it about the epidemiology presentation and diagnosis. Thank you very much. So do we have any questions, clarifications about? Yes, please. Do we have any? Okay, so if we don't have, I think it is appropriate for us to invite the pharmacology team. They are going to tell us about the drugs that we use before we talk about treatment. And it was supposed to be Dr. Lubogo, but he has entrusted us with the with an upcoming pharmacologist.
Maybe, sorry, doctor.
Yes, please.
Just for research purpose.
Yes, please.
If this case were submitted to you as a reviewer, somebody wrote it and submitted it for publication, would you be in line to accept that it is SLE?
Definitely. One thing I didn't mention is that according to the criteria, when we scored the patient, first of all, she had a positive ANA, and she scored 26 points from only the investigations that we did. There are many more that we didn't do. So she's definitely SLE, according to the American College of Rheumatology criteria. Yeah.
With the non-specific SLE cutaneous manifestation and negative specific SLE antibodies?
Yes, because, and you see that was the argument for the previous classifications. The classification has been evolving since 1999. And the literature has revealed that there are so many cases that were missed just because the double-stranded DNA was negative. And so they decided to come up with a much more inclusive diagnostic criteria that assigns scores based on the presentations. And as long as the patient has a positive ANA. Yes, because some patients have negative double-stranded DNA, some have positive. You may find someone has positive Smith but negative double-stranded DNA. So, yes, it would be classified as definite SLE based on the current criteria that was released about 4 years ago. Yep. Any other concerns? Please go ahead. Okay.
Good afternoon to you all. This presentation was prepared by Dr. Lubogo, Patrick. Unfortunately, he's not around, so I'm going to represent him. For me, it's an honor to present after my great teacher of internal medicine, and I'm still expecting senior consultant to also be here soon. So for me to stretch between two It's really an honor. More so in the midst of one of my greatest teachers of medicine, the Dean of School of Health Sciences. We are going to do pharmacotherapy. You know, this one is going to require a little more of adequate cerebral perfusion. So I would like to ask you to tense your calves. You can clench your masseters. You can stretch your upper limbs. You can yawn. You can stand up. You have a minute, please, to do all that before we start. All right, I think we can proceed. I want to start from the presentation of Dr. Yahaya, and I want you to note down the following points, 4 of them. He started by asking a question to himself, and he said, what is to be blamed? And his answer was inflammation. Then he also talked about autoreactive B and T cells. He also talked about Toll-like receptors. He talked about innate immunity, preferably the interferons. I will ask you later on in our discussion to outline for me the type 1 interferon, specifically the type 1. I hope we have second years here. We also talked about Epstein-Barr virus and loss of self-tolerance. That's where I want to start from. And say in pharmacology, we not only look at drugs, but we also do non-pharmacological management. And here, sun protection is key, as you've seen. So they are designed sunscreens with protection factors as long as it's above 25 to 50, that one can be adequate. There is lip balm with sun protection factor of about 15%. That one is also adequate. But locally, even if you advise your patients to just put on long-sleeved, at least have gloves, that one as well is adequate. Smoking cessation is also key here, and then exercise. Those ones have been proven to be effective. Now there are those where literature is not so significant, but still advised, like adequate sleep, like proper hydration, like vaccination. Remember, they've been talking about infections triggering SLE. There is also alcohol cessation as well. So those ones, alcohol, adequate hydration, vaccinations, those ones can also be added on the non-pharmacological management. Now when we talk about drugs, there are majorly 3 drugs here of interest. Drug classifications. Number 1 are the antimalarials. Number 2 are the immunosuppressants. And number 3 are the biological agents. Please note down those 3. antimalarials, immunosuppressants, and then biological agents. Now, SLE management requires the physician to first categorize it either as non-renal or renal. Because we've just seen that lupus nephritis is a poor prognostic feature of SLE. So if it is renal, management is going to be different. Allow me to start with the non-renal SLE. Still, non-renal SLE can be classified as mild, moderate, and then severe. Now, drugs for each one of them, we have different algorithms for their management. I'm just going to avail you with the drug options. The next presenter will talk about how they are used. Now, mild, in a treatment for us, the goals are you reduce on the episodes. Number two, you want to reduce on organ damage so that you can improve the quality of life of our patients. So for mild, literally I am talking about arthritis, I'm talking about mucocutaneous manifestations for as long as they are covering less than about 15% of the total body surface area. We call that one mild lupus. Now for moderate, as long as there is serositis, you know, the different can be pleural, can be pericardium, can be peritoneum. Then for as long as there is rheumatoid-like arthritis, you have joint swelling, involvement of the PIP and the DIP joints, you have vasculitis, mucocutaneous vasculitis, then that one qualifies it to be moderate. And then lastly is severe. If the moment we have major organ involvement, and here you heard Dr. Kizito talking about myelitis, can be pneumonitis, can be renal involvement, can be involvement of the CNS, those major organs, that one becomes severe SLE. And management is also different. So platelet count is also key here. Our patient here had a platelet count of 96. In mild, usually it's between 50 to 100. That one is more of mild lupus. Then if it's less than between 20 to 50, then that one is moderate. Then for as long as platelet count is below 20, that one becomes severe. So all those factors will dictate on the management options. So let's go to the drugs. Number one is going to be hydroxychloroquine. That one is under anti-malarials, hydroxychloroquine. Previously, they used to use chloroquine, but because of the severe cardiac toxicities, conduction, as well as cardiomyopathies, it's called what? Hydroxychloroquine. That one has a superior safety profile compared to chloroquine. So that one was the first drug to be approved for use in SLE since 1950s. So the first drug is hydroxychloroquine. That one being an antimalarial, here the mechanism of action is a little different. it's more of it's a lipophilic drug, so that one penetrates cell membranes easily, accumulate in lysosomes as well as endosomes, and those two dictate the mode of action. In lysosomes, mostly it's going to interfere with expression, antigen processing. You remember once antigens are phagocytosed, they are processed and then presented via MHC2. Now that process and then the subsequent, the next cascade of enzyme activity, gene expression to bring about pro-inflammatory cytokines is going to be impaired. Why? Hydroxychloroquine accumulates in lysosomes, increases the pH, and therefore impairs antigen processing and subsequent pro-inflammatory cytokine production. That's the first one. And Dr. Yahaya talked about that. The next mechanism still related to that is its accumulation in endosomes, and that one is related to the toll-like receptor signaling. Still, that one also ends up in activation of genes for pro-inflammatory cytokines. So that one as well is going to be cut off. That's how majorly hydroxychloroquine works here. It's a cornerstone drug in management of SLE, and it's indicated in almost all forms of SLE, unless if it's contraindicated, like in cases of G6 phosphate dehydrogenase, where there is increased susceptibility to hemolytic anemia. But otherwise, the rest of the SLE, hydroxychloroquine is indicated. The major side effects of that drug is usually in the initial stages, a patient can present with GI upset, but with the time, that one subsides. Now, because we are going to administer hydroxychloroquine for a little prolonged period of time, that drug is associated with retinal toxicity. And therefore, after 5 years of drug therapy, a patient will be required to undergo fundoscopic examination. And then after those 5 years, it's done almost every year for the rest of the patient's life, for as long as they are still on hydroxychloroquine. And once there is evidence of retinal dystrophy, then you can choose to discontinue the drug and then look at other options. To make Dr. Aderu happy, this drug is very safe in pregnancy and can be utilized. So that one is the first drug, hydroxychloroquine. Now that one can be is to help us with maintenance. But if a patient comes with flares, the most important drug then becomes a steroid. Preferably, you can choose to start with IV methylprednisolone for a short period, usually 1 to 3 days. And then you can switch to oral prednisone. You pick that. Because of, corticosteroids are good have a rapid anti-inflammatory effects. So they will help you with the flares, and then you can maintain the patient on hydroxychloroquine plus low dose oral prednisolone. We pick that. So that one is for mild SLE. If in case it is refractory, then you can think about other immunosuppressants, preferably methotrexate or azathioprine. Methotrexate, it is the dihydrofolate reductase inhibitor, right? So that one interferes with folate metabolism. And because of that, if you're administering methotrexate to your patient, you know you have to do folate supplementation, right? So that one, the patient must receive daily folic acid supplementation. Methotrexate is for purine biosynthesis, so I think you're not surprised. We want to reduce on B cell as well as T cell proliferation. So we cut off folic acid supply, we cut off de novo synthesis of purines, and we are good to go. Azathioprine is also a metabolite. Though that this is a prodrug which is faster, which has to be activated fast too. Azathioprine is fast activated too. I'm listening. Okay, you have to activate it to 6-mercaptol purine. And you know that one is also going to help us in the DNA synthesis. We cut off that, we are cutting off B cell proliferation, and therefore we are cutting off inflammation. So that one is for mild. For moderate, the same protocol. Hydroxychloroquine, we said it's a cornerstone drug. Add there a glucocorticoid, depending on presence or absence of flares. Make sure you have the low dose glucocorticoid. And then from there, the other first line agent for moderate will be methotrexate. Methotrexate was second line in mild. It's first line in moderate. You have to add it as well. Then azathioprine, it's here also a first line agent for moderate. Once you have refractory SLE, then you can think about, now we are crossing over to biological agents. And preferably here, the drug of choice is belimumab. Belimumab. We have some yatus here, not so? Belimumab. For yatus, as long as you see MAB, that is a monoclonal antibody, and it's therefore a biological agent. Belimumab was first approved for SLE use in 2011, but in 2021, it was also approved for lupus nephritis. So belimumab is going to be for refractory moderate. Belimumab blocks, I really don't want to take you too deep into the pharmacology because cerebral perfusion may not be adequate, but it's more of a B lymphocyte stimulator receptor blocker. So it's going to block the receptor on the B cells where B lymphocyte stimulator, as the name implies, is supposed to bind, and therefore you're not going to have B cell activation. The goal is to reduce inflammation, and we are there. Then if it is still refractory to belimumab, which is our second line therapy in moderate, then the options for third line is going to be MMF, mycophenolate mofetil. Sorry that there is no power, but you can write MMF. It's mycophenolate mofetil. That one is Dr. Delu can't be happy with that drug because some researchers have talked about it being a potential teratogenic agent. So you have to discuss that if the mother is wishing to, okay, if your patient wishes to become pregnant, and see other options. That is mycophenolate mofetil. But the good news for that drug is it has still a superior safety profile as compared to its next one in line, the cyclophosphamide. So MMF is third line in moderate, mycophenolate mofetil. That one impairs guanosine synthesis in the B and T cells, de novo synthesis. Then if we go to the severe form of SLE, the options we have are still the same: hydroxychloroquine plus glucocorticoid, then plus MMF. Now, second line here is going to be cyclophosphamide. I want to ask a question to the congregation. Every time someone talks about cyclophosphamide, there are two key side effects that come straight into our minds. Just mention them for me, then we proceed. I'm ready to take the first one. Hakol.
The ones I know is hemorrhagic cystitis.
Hemorrhagic cystitis. Azoospermia. Okay. Any other? Abongoto, you seem to be having an option. So that means for the third years, if you have hematuria, hemorrhagic cystitis can be a possible differential secondary to cyclophosphamide, right? In addition, yes, please.
That drug also causes myelosuppression.
Myelosuppression, very important. Those two are the major side effects: hemorrhagic cystitis, and then bone marrow suppression. Now, for the cases of, Cole talked about azoospermia, not just azoospermia alone, but also even in the females. Yeah, so that drug impairs fertility for both males and females. So you definitely have to also rethink if your patient, you are planning for pregnancy or conception in your patient. So the two drugs we are now thinking about are mycophenolate mofetil and then cyclophosphamide. Both of them are potential teratogens, but again, this one is a potential gonadotoxic agent in addition to hepatotoxicity of that same drug. This is where we are here. Cursor cannot be seen. Okay. This is where we are here. Cyclophosphamide being a third line for severe systemic lupus erythematosus. Cyclophosphamide. That one is an alkylating agent. If you remember, you have DNA cross linkage, and therefore you're going to impair DNA synthesis and replication, preferably in the B and the T cells, and therefore you're cutting off inflammation. I think there you're good to go. Then the last drug, our third line drug for severe, is again a monoclonal antibody. This one here, rituximab. This one is called rituximab. It's again a biologic. So I told you we have biological agents, we have immunosuppressants, and we also have anti-malarial agents. So rituximab, that one is going to be the last resort in our severe systemic lupus erythematosus. Okay, that one is anti-CD20. You know where the CD20 receptors are? B cells, Okay. And when Dr. Yahya talked about complement-mediated cytotoxicity, it is what rituximab is targeting, complement mediated cytotoxicity. I think we are good to go. For that is for non-renal SLE. The options are there. Now, when it comes to lupus nephritis, management is a little different. Remember, for lupus nephritis, you have to start by doing biopsy to confirm the histological nature of the lupus. It's divided into 6 classes. I'm not going into details there, but classes 1 and 2, those ones are fair. And glucocorticoids, in addition to hydroxychloroquine, are enough. Now for classes 3, 4, 5, even 6, you need to manage it in 2 phases. You have an initial induction phase and then a maintenance phase. Now in the induction phase, may not be clear, but it's okay, you can listen. So in the initial induction phase, that's where you're going to use now mycophenolate mofetil. That's another indication for MMF in this SLE. One, we used it as, you can see it here. It was our second line in moderate. Now we can also use it as an induction therapy in lupus nephritis. And the treatment can go on for about 6 months. Usually it stretches from 3 months up to a full year. But research has found out that 6 months are effective. Then in addition to MMF, you can choose to add there a glucocorticoid, and we say that is going to be prednisolone. If there is a flare, we start with IV methyl prednisolone. All right, then you keep tapering. You've seen you have to keep tapering the corticosteroid dose until you achieve the lowest possible. Because of hydroxychloroquine, this is possible. One of the advantages of hydroxychloroquine is it is the only drug that has been shown to improve, actually to prolong survival in these patients. But also it helps with the inflammation. So then you require a lower dose of the corticosteroids. If your patient improves during the induction phase of MMF, then you can continue with MMF in your maintenance phase. But if the patient does not improve, then that means you're going to bring in cyclophosphamide and all its side effects. Once cyclophosphamide is able to record improvement, then you can go back to mycophenolate mofetil. If it doesn't, then we are going to bring in a new drug, calcineurin inhibitors. And the most commonly used calcineurin inhibitor at the moment for us is tacrolimus. But tacrolimus impairs a number of physiological responses in the body, including electrolyte imbalances. So that means if a patient is on tacrolimus, you must do continuous laboratory monitoring for as long as the patient is on tacrolimus. So you do a CBC, make sure there is no anemia. You do renal and liver function tests to make sure that you don't have hepatic injury. You have to do a random blood sugar to check, because it is also likely to cause hyperglycemia. So the patient has to be monitored continuously for as long as they are on tacrolimus. And that one informed research, and in 2021, a new drug called voclosporin was approved for management of lupus nephritis. The drug is called voclosporin. It's a calcineurin inhibitor, approved recently in 2021. There has been a lot of research for the last 10 years. The first drug we saw was belimumab. Now we've seen this voclosporin we are yet to see other drugs. Usually, that is how you have to manage. Let me not take you into other drugs for now. What I want you to know, lastly, is another biological agent called aniflorumab. That one was also approved in 2021. Dr. Yahya has gone, but he talked about interferon gamma. That drug is anti-interferon gamma, interferon alpha, we are talking about the type 1s, interferon alpha, beta, and then this one is what? That one. That W1 is what? W is omega. Hey. So those are the type 1 interferons, and aniflorumab recently approved targets interferon alpha. Okay, then lastly, so you've seen 3 new drugs. Belimumab, that was 2017, aniflorumab, that was 2021. You've seen volcosporin, that was also 2021. They have come on board. I don't know if they are available in our market yet, but I think you as prescribing physicians for the near future, you should be aware of those options. I told you MMF is teratogenic as well as cyclophosphamide, but I told you hydroxychloroquine is safe and has been shown to prolong survival. Now, adjuvant therapies. All patients, patients with SLE have been found to have vitamin D deficiency. So you need to provide vitamin D supplements. Then we talked about the antiphospholipid antibodies, you remember? And we talked about them in terms of thrombosis. So that means if you check for antiphospholipid antibodies and you find them reactive, you definitely have to add an anti-coagulant or anti-thrombotics. If you find those antiphospholipid reactive. Then the other ones are statins. The moment you do a lipid profile and you find LDL more than 100, you will have to add a statin. Then S inhibitors or ARBs in lupus nephritis, for as long as you do urinalysis and you find proteinuria of more than 0.5 grams, you still have to add an SCEI, captopril, or an ARB, losartan, those ones, you add them. Then if they really are patient, most of the ones of lupus nephritis, if they advance to end-stage renal disease, definitely you either have to think about either dialysis or transfusion. Okay, now in summary, we've talked about antimalarials, which is hydroxychloroquine. It's everywhere. And then we've talked about steroids, either as IV methylprednisolone or per oral prednisolone. And we said you have to taper the dose and achieve the lowest possible. And then we've talked about other immunosuppressants, which are, number 1, azathioprine, number 2. Cyclophosphamide, number 3. Methotrexate. Cycloserine can also be used. And then lastly, the biological agents. Belimumab for moderate. And then the other one is rituximab for nephritis, lupus nephritis. Do you remember the new drug that has been added? Which one is it? Aniflorimab. And you remember the recent calcineurin inhibitor added? Voclosporin, in addition to the previous tacrolimus. All right, I want to stop here. Thank you for listening.
Thank you so much, Mr. Kalema. Doctor to be, right? You've done so well. I'm really, really, really happy. I think he deserves another hand clap. He did even much more than we required him to do. But it's okay. It's very okay. Do we have anything to add before we summarize quickly?
Mark, I just wanted to remind ourselves that in pediatrics, the first manifestation could be congenital, manifesting as a heart block in a newborn. Heart block, heart failure, child very sick. And this is all resulting from crossing of the antibodies, the raw antibodies, destroying the conduction tissue of the heart. Yeah, but the management then will have to follow whatever we have been talking about. Eventually, SLP peaks in childhood at around 12 years. The child I was telling you about was 10 years. His name was Mwanguzi. He did not Kuanga. So the peak for children, about 12 years. Most of them come around there, but an occasional neonate comes with a heart block or appears with a heart block, but they often also may have a rash on the skin, which can be discoid actually, or other forms of rash. You don't need exposure to sunlight at the neonatal period to get those rashes. So that's all I wanted to add a little bit. So the commonest cause of congenital heart block is S and L and E. True? Sort of true. That's the commonest cause of congenital heart block.
Okay, thank you, Professor. Yes, Akon?
I also wanted to inquire from Mr. Kalema. One of the drugs we have seen being used for a longer period of time in lupus nephritis is the cyclophosphamide. And we have seen its adverse effects, which are very dangerous. If it's the option we have to use, are there any interventions you can use to minimize the adverse effects of cyclophosphamide?
Okay, we say that number one, you hydrate the patient pre, intra, and then post medication. That's number one. So that you improve on renal expression. But number two, there is a drug called Mesna. I never wanted to go into details like that far, but Mesna is also can be used to improve toxicities.
All right, any other? All right, so let's quickly summarize it. Dr. Tolo has not been able to join us. He's still caught up, but he sent his work through, so I'll share it. Mr. Kalema has already discussed the goals of treatment, as you see there. I'll not go through that so much. And then he hinted about the disease spectrum. A patient may present as a flare. A flare means when they have the active disease, having the symptoms. A patient may be in remission where there are no symptoms, or we can do some tests to determine the disease activity, whether it is mild, moderate, or severe. He hinted about this. He talked about photoprotection. I think I shouldn't stress so much. Talked about cessation of smoking, immunization. And here I wanted to emphasize hepatitis B. We have seen some patients who come with fulminant hepatitis following administration of immunosuppressants. So before you treat a patient, check their hepatitis B, serostatus, and if they are negative, vaccinate. Please vaccinate. And now we have COVID, HPV, influenza, pneumococci. Many of these are limited by your pocket. If you have some money, these vaccines are available. But hepatitis B is a must. The other thing is screening for malignancy. Patients with SLE have an increased risk of developing cancer. I won't disturb you, but it is a spectrum. Many of them are what we call the liquid tumors. Lymphoma, because of the constant B-cell activation. There could be a mistake that results into a mutation which leads to a lymphoma. Leukemia, they are what we call plasma cell dyscrasias. The 4th years. Francis, you have finished rheumatology. Can you give us one example of a plasma cell dyscrasia? You skipped that part. So like multiple myeloma. Things like multiple myeloma can develop in patients with SLE. And then there is what we call the age-appropriate cancer screening for things like CA prostate, isn't it? Okay. Screening for osteoporosis. Remember, these patients are on glucocorticoids, but also the pro-inflammatory state is associated with the bone loss. So there are things like the DEXA scan that can be done to determine your risk of osteoporosis. This is very important. Cardiovascular disease risk screening, lipid profile, body mass index, high blood pressure screening, diabetes, mellitus, and manage appropriately, because this is actually cardiovascular disease, I think, is the second cause of death in patients with SLE, behind infections, if I may remember. So screen for that. He talked about diet and exercise. Our patients have low serum levels of 25-hydroxy, vitamin D, because they don't want to get exposed to the sun. So vitamin D supplementation is advised. The baseline drug for SLE is hydroxychloroquine. And I'm sure you have had it in COVID as well. Its immune modulatory effects. It never works. Yes, people say it never worked. People concocted that, apparently. But it is a baseline drug. So all our patients should be on hydroxychloroquine, and those are the advantages. He talked about what mild disease means. These are patients who will be on hydroxychloroquine and a short course of steroids. NSAIDs also have a role, especially in patients in whom you have ruled out renal involvement. And they are very important in management of arthritis. Arthritis will not respond to paracetamol, morphine, usually needs these non-steroidal anti-inflammatories. He talked about what moderate disease means, and here, that's when we bring in the immune suppressants. The other thing I want to add to his presentation is that sometimes we choose an immune suppressant depending on the predominant feature. If the predominant feature of SL is arthritis, then methotrexate is first line. We are together. Because it is, it reduces, it lowers disease activity in patients with the arthritis. If a patient presents with neuropsychiatric manifestations, then cyclophosphamide is first line, regardless of whether it is moderate or severe. And then renal disease, as he said, MMF. So sometimes you choose depending on the predominant feature. But the methotrexate is for arthritis and mucocutaneous disease, mainly. He talked about belimumab as a second line, severe disease, and that's why you see that cyclophosphamide and MMF are in the severe disease, because they are indicated for CNS or renal impairment. If a patient fails on the immune suppressants, we bring in rituximab, and one of the new agents is talked about, anifrolumab, which is an interferon inhibitor. Rituximab is available here in Uganda. A dose is about 900,000 only, and you usually receive a dose every 6 months. So make money in case you need to buy it. Our prognosis, those are the things that increase the mortality: kidney disease, hypertension, if you're male, if you are, so in the children, as Professor has already talked about it, and then the elderly, low socioeconomic status, to mention but a few. Presence of antiphospholipid antibodies, very poor prognostic factor because it's associated with venous thromboembolism. So before I close it up, remember most of our patients are female of childbearing age. You need to give them advice about conception. We have already talked about the anti-RO and anti-LA, which increase the risk of neonatal lupus and congenital heart block. You discuss it with them. While a patient is on immune suppressants, we advise that they get double contraception. Double. BTL is permanent. So something like, I think all the contraceptives have some failure rate, if I remember very well. Is there one apart from abstinence, which is, that one is 100%, isn't it?
But the failure rate is higher.
On abstinence. Remember, that one is not abstinence. Okay. So almost all of them have a failure rate. So we advise that if a patient is on drugs like methotrexate and cyclophosphamide, especially those two, we need to double. If you're using safe days, you also add condoms, you know, so that you prevent teratogenicity. Usually discuss childbearing goals with the patient. if they are planning to get pregnant, ask them, we need to switch the immunosuppressants. Things like methotrexate 3 to 6 months before conception. That's when you should stop the drug. The other important thing is that, of course, antenatal care. But you need to tell them that such pregnancies are difficult. I don't know what word they use in obstetrics.
High risk.
High risk. My obstetrics is disappearing. High risk what? Pregnancies. There is a increased risk of pregnancy, gestational hypertension. Of course, miscarriages, especially in the second one, trimester. There is increased risk of gestational diabetes mellitus. You have increased risk of preeclampsia and eclampsia, and then venous thromboembolism, DVT and PE. So they must be, I think these are guys who do antenatal care every month to screen for those. The other thing is, once they are pregnant, we don't encourage them to take NSAIDs because research shows that there is increased risk of PET. But again, aspirin is given, isn't it? So I've not gone deep into. Nowadays we are giving aspirin to prevent what? To prevent PET in patients in OBS-GYN. The other thing to discuss with them is delivery. How will they deliver? Is it SVD? Is it C-section? Which one do you think is safest? C-section in the good hands, isn't it? Because it is a controlled environment in quotes. So and it's fast. That is a C-section you want someone like Dr. Delu to do. Not an intern what? Who is going to spend 45 minutes on the table. You want someone who is going to take about 15 minutes quickly. The baby's out. Eh? So those are the things you discuss with the patient so that they plan ahead. We are together. Yes. If a patient develops a thromboembolic event during pregnancy, we normally use heparin to treat because warfarin we know is teratogenic, and also in the third trimester it increases the risk of bleeding. So heparin is preferred. And if you have been out there in the community, do you know how much Clexane costs? 45. So you imagine someone is getting twice daily. That is 90,000 every day. So it is quite expensive. You need to discuss these things with the patient so that they prepare. And you treat, you anticoagulant until 6 weeks after delivery. All right. Having said that, I think that is the end of our presentation. Thank you so much, the presenters. Mr. Doi, Mr. Kalema, Dr. Yahaya is gone. Myself, thank you for attending our audience. And for me, the bottom line here is that SL is actually common. I have seen 3 patients in Soroti ever since I came. 3. Of course, all of them are female of childbearing age. This is just one of them. There is another who couldn't afford to investigate thoroughly. I think you saw the patient. But they are there, and many of them come from the church. I don't know which church is common around here, but many of them are coming from the church. after prayers, 2 years, 3 years, and many of them are coming with severe disease.
It is the sick people who actually seek healing in the church when they have faith get treatment elsewhere.
Exactly. And that is where we come in. If you are in a health center for district hospital, don't think about malaria all the time. Typhoid. Someone was treated with malaria 2 weeks ago. They come, you do RDT positive. Let's give quinine. Let's give artesunate. So guys, let us think outside the what? The box, so that we help our patients much better. This patient is actually doing well. She's, the flares have gone so far. Maybe now because of the rainy season, we don't know what will happen. But the mucocutaneous lesions were healing. She's actually back to work. And she understands that she needs to be on the treatment. The witchcraft is now demystified, but we don't know. Sometimes people revert back to their thinking. So let us look closely. Let us examine patients. One of the problems we are having as doctors, we don't examine. You just sit on a desk, you write symptoms, fever, headache, malaise, do BS. You don't examine. You don't expose patients. You miss these rashes, you miss the arthritis. And by the way, sometimes patients don't know how to describe these symptoms. Like you saw in our history, the patient said she's having hypopigmentation. But was it really hypopigmentation? It looked something different. So please examine the patients. I will hand over to my senior colleague, Professor Dietz, and maybe Professor Kiria to close it up.
Thank you very much. Let's pack our hands. You've done excellent. You've taught us, you've reminded us, and you've provoked us. We thank you, Internal Medicine Group. And these sessions are supposed to be there. We want them. They are interdepartmental. They are part of the ways that we deliver the curriculum. So even if no one stands before you teaching you SLE, it's done. The next presentation will be in 2 weeks' time, and that will be on the 14th of March. And which department will it be? Obstetrics and gynecology. I was waiting for it.